welcome everybody on this rather sunny, hot week. Thank you for attending, and I hope to be able to educate you a little bit and share some knowledge about atypical leg ulcers, which I see in daily clinical practice. For those of you who don't know me, I'm a skin cancer surgeon and I do some cosmetic surgery. I'm based at King's College Hospital here in London, and I see a lot of wounds. I see a lot of ulcers in my kind of cancer role, but I also see leg ulcers in my general dermatology role. So I hope to share some of that experience with you. And now, as you've been told, I do like to keep a session engaged and interactive as much as possible. So I will be asking questions. I'll be giving you some information, and then I'm going to be sharing some photographs. And I'd like your opinion on what you think the ulcer is, because I do think that it's, you get the most out of a talk like this when we have a little bit of back and forth. And also it's the end of the day, we want to be educated, but we also want it to be a bit fun. Okay, so with that said, we're going to go into leg ulcers beyond the day-to-day. And the objectives, as I've shared with you, you already see a lot of leg ulcers and tissue viability. You know how to deal with the common leg ulcers. It's when you are faced with something that's not healing, that you need to think laterally, and I'm here to help you think laterally. So I'm going to be sharing with you some images and some details of some not so common leg ulcers we see here in dermatology, the causes, how to investigate them, and how to treat them. Okay, so just to share some statistics with you, we know that around 1 to 3 in 1,000 people experience leg ulcers. This increases as people grow older. When you're above 80, it increases to 20 per 1,000. And the majority of people have got venous leg ulcers, but there are 20% of those who do have arterial disease as well. And so it's really important that we tease out the ones who have got arterial disease. And I think as tissue viability specialists, you are very good at teasing that out, and you're very good at accessing, scans and, ankle breaking pressure indexes, etc., to diagnose what type of vascular insufficiency there is. Where I think, more of a broader knowledge is required is when it's not necessarily arterial or venous, and there are many causes of leg ulceration, and I'm apologetic in advance for the busyness of the next 2 slides, but this will show you how many different causes of leg ulcers there are, which I'm going to share a few of them. So obviously there's vascular insufficiency, of which it could be arterial or venous, thromboembolism, cholesterol embolism, smoking related thromboangiitis obliterans is one of them. You've got the microcirculatory problems, which we're going to chat a little bit more about, because I see more and more of a specific skin manifestation due to this microvascular disease. And we'll chat about how to manage that. Hypertension can cause ulcers, as can other conditions which increase the thickness of your blood. I was only told yesterday, when the weather was at 40 degrees centigrade, by one of our stroke physicians, that when we get high temperatures or extreme temperatures, we tend to see more strokes, and that's due to the hypercoagulability, it's thought, but it can also cause ulceration because of emboli. Physical or chemical lesions or pressure ulcers you see a lot of in your practice, trauma, burns, and external agents such as corrosive agents used for sclerotherapy, for example. Bacterial, viral, infectious causes, parasites are common in different parts of the world, and we'll be sharing some of these with you today. Now this doesn't end here, because this is an exhaustive list. You've got areas which have got poor nerve supply, so lower sensation to those areas, such as diabetes, for example, which is a common one, but other neurological conditions can also cause neuropathic ulcers. Blood vessel problems, hematological diseases, right the way down to metabolic diseases, and certain chromosomal disorders such as Klinefelter's, for example. Due to the various nature of these syndromes, you can have trauma, or you can have circulatory problems resulting in ulceration, and it can be associated with other autoimmune problems as well, that we'll discuss. So we do you all are very au fait with using investigations for leg ulceration. How many of you have ever had to refer for an MRA or an MRI for your leg ulceration? Could you put it in the chat for me so I could have a look and see how many of you? Can you just put yes so I have a thing of numbers? Okay, Q&A. You can write in chat yes. I've got a few yeses coming in. Yes, oh, fantastic. Yeah, looks as though some people are saying no, some people are saying yes. Okay. Okay, reasonable number with no or yes. Okay, so we're going to have to take away the chat too. Yeah, okay. So coming on to those are the investigations. Commonly, though, for investigating leg ulcers, we use ankle brachial pressure index, we use ultrasound, Doppler. You can have other investigations such as skin biopsies when they're needed, and you can have other investigations such as magnetic resonance angiograms and the MRI to look for osteomyelitis particularly, but also to look for arterial disease, which is the MRA. Right, so coming on to the nitty-gritty, the fun part of the talk. Now, I'd like somebody in the chat to describe to me what they see on the left-hand image in this photograph, so the big image that we have. How would you describe this to a person? Say you were, not sure about this is a non-healing ulcer. How would you call somebody and say, do you know, I have this on someone's leg? What terminology would you use, first of all? Anybody? I'm having a bit of difficulty with
I think it's the chat function, Sweta, is not working brilliantly at the moment. I'm seeing in the chat, in the questions, people are sort of putting descriptions in there. So Pink, if you could maybe look at the chat.
You mean the Q&A?
It's in the Q&A, but the chat function, people say they're having problems with it, seems to be disabled. So people are putting answers into the Q&A. There's somebody that's put granulating in here at the moment.
Okay, if you could just shout out for me what they're saying, because I've got my Q&A open, but I can't see them because I can't scroll down it.
Okay, so we've got people saying looks granulating, other people saying it looks fluffy. Someone's commented on the raised purple edges or peri-wound erythema, overgranulated, PYODERMA.
Okay, so I kind of have skipped the slides because with this, not to say that you wouldn't have guessed it, everybody, without me skipping the slides, but you're absolutely right. This shows an ulcerated, I would have said, plaque on the left. Is it the left? On the lower leg. Looks like the right, actually, the right medial lower calf. You can see definitely a purple overhanging edge. What do you see at the base of that? How would you describe the granulating base of this image? Anybody in the chat? Have you got any answers?
We've got granulation and sloughy.
Yeah, what color would you say this is?
People want to put some ideas into the Q&A. Overgranulating. Let's have a look. A lot of people saying overgranulating. Pink, sloughy infected.
Yeah, so
pink granulation.
Yeah, so you've got yellow and pink there, haven't we? And we've got almost like a cobbled or a cobblestoned base to it. So, which is why you are seeing some people describing it as overgranulating. So all of those things are correct. You've got the purple overhanging edge, you've got surrounding erythema. It looks as though this ulcer is sore on someone's leg. You've got some purulent discharge, and you have got a pink yellow undulating or cobblestoning base is how I would describe that ulcer. Now, you've got a similar lesion on someone's cheek there. How would people describe the lesion on this lady's cheek on the top right image?
Black necrotic is coming through.
What's the base of it though? What is the actual outline? The back, there's a black necrotic center. Does anyone know what that necrotic center in kind of skin terms is called?
Eschar, someone's put.
Exactly, very good. So eschar. So there's a black eschar in the center, and what about the surrounding?
Just to say, Sweta, that the chat function or everybody is working now. So if you wanted to use that, that might be easier, and Sweta can see that then.
I can see, well, I can't scroll down these things, so I might need you to just monitor.
Yeah, sure.
Thank you. Okay, so I think for the interest of, in the interest of time, I will describe the lesion on the cheek. The lesion on the cheek I will describe as a large purple nodule with a central black eschar. The lower legs, you can see on the bottom right image that you've got things starting off with a purple nodule, which with the eye of faith, in some of them, you can see a bit of a pustular center to it, or a yellow center to it. Now this is, as you all have rightly correctly guessed, this is pyoderma gangrenosum. Pyoderma gangrenosum is an inflammatory ulcer. It's thought to be associated with autoimmune disease. Particularly, does anyone know which type of autoimmune disease it is on the slide?
Rheumatoid.
Can be associated with rheumatoid. Most commonly, inflammatory bowel disease. Inflammatory bowel disease meaning conditions such as ulcerative colitis and Crohn's disease. And it can be associated particularly with UC. It can also be associated with certain hematological malignancies, myelodysplasia, for example. It can also be sometimes associated with certain cancers, particularly hematological cancers such as myeloma. So those are the things to be aware of when you see this condition. In the majority of cases, these lesions are idiopathic. So you find that they have got pyoderma gangrenosum, but pyoderma gangrenosum is not associated with any background condition. If they're young and they have pyoderma gangrenosum and you've got a tissue diagnosis confirming pyoderma gangrenosum, then most of the time further investigations are not needed, but in the majority of time we do a bowel screen, in particular looking for fecal calprotectin, get them seen by a gastroenterologist. If they have got bloods which are abnormal, we'll have them seen by a hematologist, but this is after a tissue diagnosis. Now, can anyone tell me in the chat that what you see when you biopsy pyoderma gangrenosum? Has anyone heard of the term or been sat in an MDT where pyoderma gangrenosum has been discussed?
No comments at the moment, Sweta.
No, I've heard the chat go to 35, so I can't see anything.
So we've got about inflammatory infiltrate.
Yeah, so does anyone know what type of cell what type of histological disorder is this? So in skin terms or dermatology terms, what do we call this? What type of dermatosis do we call this? Yeah, anybody?
People aren't sure at the moment.
No problem. So we call this neutrophilic dermatosis. It's on the screen on the top bullet point. Autoinflammatory disorders, but this is called a neutrophilic dermatosis. There are other neutrophilic dermatoses, and this is a diagnosis of exclusion. Usually, when we have excluded other neutrophilic conditions, we tend to diagnose them in the right clinical context. Obviously, if you've got an ulcerating purple nodule with overhanging edges, you've got a neutrophilic dermatosis on histology, then you can safely say that this is pyoderma gangrenosum. So if you see a purple nodule or multiple purple nodules on someone's skin, which is ulcerating, or even if it hasn't ulcerated and you think, actually, this is not typical for what I see day to day, there's some signs of ulceration, rather than treating for a normal venous or arterial ulcer, consider doing a skin biopsy, consider calling your local friendly dermatologist, and who will make a diagnosis for you. And the tip to remember here is that most venous ulcers or arterial ulcers do not have a purple overhanging edge. They may start off with ulceration. They almost never start off with a nodule formation. And nothing is impossible, but usually you will have these purple nodules with a central ulceration or pus formation, which will give you a clue to this being a neutrophilic pyoderma gangrenosum. Any questions on pyoderma gangrenosum so far before we go into treatment of it? Raised purple edges. I'm seeing all this chats coming up now.
No, there's no questions in the Q&A, and there's nothing in the chat, Sweta. Right. Oh, there's a question here about pyoderma under compression therapy. Is that contraindicated, or is that okay?
Okay, so pyoderma is an inflammatory skin condition. So the treatment for pyoderma gangrenosum, once the diagnosis has been made, is immunosuppression. So immunosuppress with, you can use, if they're small lesions, you can use topical steroids, potent topical steroids, such as Dermavate. You can use oral steroids, but cyclosporin is a common IV immunosuppressant, which is used to control pyoderma gangrenosum. Because pyoderma gangrenosum isn't a vascular condition, and it's not really arising due to background lymphedema or vascular insufficiency, there is no role in compression in pyoderma gangrenosum. Has anyone compressed pyoderma gangrenosum before? Is that why you're asking? Anybody?
People are saying always, yes. They do. They
do for pyoderma gangrenosum, and they have. This is with adjuvant to treatment with immunosuppression, or is this without immunosuppression?
I think it's with treatment as well.
Okay.
People are asking, is this a lifelong problem that could reoccur?
Yeah, so usually it arises with underlying autoinflammatory conditions or autoimmune conditions. So it can be a problem that can recur. We don't tend to associate, we tend to immunosuppress. So when we immunosuppress, we treat the underlying problem as well, which is almost always autoimmune, such as ulcerative colitis, if there's inflammatory bowel disease, unless it's associated with a malignancy. Obviously, in a malignancy, we wouldn't be suppressing them, but once you treat the underlying malignancy, the pyoderma tends to settle. Can this recur if a malignancy or the autoinflammatory or the autoimmune condition recurs and becomes active? The answer is yes. So it really does depend on the background medical problem that is associated. If it's idiopathic, usually once you have treated it once, it tends to go away without recurring years later, unless there is an active autoimmune problem found associated with it years later. So does that answer people's questions? And as far as I'm aware, we would only ever consider compression if there's a lot of lymphedema associated with the ulcer, or they're on adjuvant treatment with immunosuppression. I wouldn't advocate it as a solitary treatment for pyoderma.
Yes, people are happy with that. Thanks, Sweta.
Okay, fantastic. Okay, so going on to the next slide. So now we're coming on to, we're going to skip away the autoimmune causes, and we're going to go to the infective causes of leg ulceration. Now, I'd like you to focus on the top right-hand picture. And the top right-hand picture shows a gentleman with Afro-Caribbean skin with extensive ulceration. Can someone describe to me what they see in the chat, in the Q&As or the chat Really surprised that you don't see a role for in the yes, medical therapy is critical. Okay. I do see a role for it, Alison. I just don't see it as a solitary treatment for it. It should be associated with immunosuppression, if they are associated with autoimmune disease. Does that answer your question, or are treating the underlying problem? Because almost always they are associated as an adjuvant treatment for sure, but not as a solitary. Yeah. Okay.
I think there's the concern, Sweta, in terms of the pyoderma, particularly from the legs matter point of view, that any wound on the leg has the potential of becoming more complex, because they could have some underlying more, you know, that's maybe not being detected at this point. And we always would advocate compression as you say, as an adjunct to healing.
As an adjunct, if it's not healing with medical treatment.
Yeah.
Pyoderma in itself, when it's a diagnosis, is an autoimmune condition, and the treatment for it would be topical or oral immunosuppression if there's no underlying. Thank you, Alison. I agree with that statement, that not compression alone, because if you think about what's causing the pyoderma, what's causing the pyoderma is not a problem that can be treated with compression alone. Yeah. So if you think about the etiology, which is why I was trying to go into the etiology of the neutrophilic dermatosis associated with autoimmune problems. So if you think of the pathophysiology that's causing this particular ulceration, and bear in mind, not all pyoderma ulcerates. Most of the time, when it's not being treated appropriately, that's in the early stages, that's when it ulcerates. Sometimes it can ulcerate quite quickly. Sometimes, you know, this is a condition where when people go into hospital, you know, the orthopedic surgeons often call you saying that there's this huge ulcer and this, like, you know, this may be an ectrodizing fasciitis, and the patient's really, really unwell, and you go in and you biopsy, and it's because they've had trauma to the area because of, you know, pre-op assessments or injections, and that's resulted in the ulceration process, which has become bigger. So often we then immunosuppress and things get better, but the treatment is not surgical, it's not compression as a primary treatment. Adjunct, totally depend, and as you say rightly, there may be underlying venous disease for which there, you know, and lymphedema, which would help the process of healing with immunosuppression, and it may also mean that we have to use less immunosuppression, you know. So yes, as an adjuvant for sure. Moving on from that, we will chatting about the lesion on the leg on the top right image. Can someone describe to me what they see on this Afro-Caribbean man's leg?
We've had a range here: leaking ulcer with muscle visibility. Mm-hmm. They're wondering, overgranulation on both feet. Fungating mass is another one.
Okay. So first of all, it's a well demarcated large ulcer on someone's leg. Yeah, bilateral. You have got areas where the pink is visible, and then you've got areas of full thickness ulceration. So the pink that's visible that's dermis. And what the ulceration that's visible, you're right, it probably has gone down to the muscle. You've also got islands of sparing of ulceration in this, which you didn't see in the previous one with pyoderma, and you don't see any overhanging edges here. I personally don't see any fungation. We'll come on to fungation later. If you're talking about I'm talking about the left-hand image, actually, sorry. That was my rights and lefts getting mixed up for you. So on the left-hand side, you've got a gentleman with two ulcers, and that's the image that I'm talking about. So on that image, there's no fungation, but on the right-hand image, which you're right, there is fungation. So on the left-hand image, left top, what would be your differential? What things would you consider? You've been compressing this man's legs. He has arrived recently to the UK. He's not a resident of the UK. What things would you ask this gentleman, and what would you think is going on? Anybody?
We've got sickle cell here in the chat, Sweta.
Okay. Anybody else?
TB or trauma.
Okay, I like that. Okay, so I think that we have hit on TB. So this is something called a BURULI ulcer. Has anyone heard of the word BURULI ulcer? It is a form of mycobacterium that causes this ulcer, the type of mycobacterium that causes this ulcer is called Mycobacterium ulcerans. BURULI ulcers commonly found in West Africa, particularly in Ghana, present also in Australia. It is treated with a course of antibiotics, strong antibiotics for 6 to 8 weeks, it says here, but 6 to 12 weeks it can also take. With a treatment with this can be aided again. I mean, in this gentleman, you see there's no lymphedema, there is no venous disease going on there. So this gentleman didn't really require any treatment with compression, but if there were those things, then you could use it. But the treatment for this is antibiotics, as if you were treating TB. Anyone seen a BURULI ulcer? You can put it into the Q&A section for me, or chat. I can see the Q&As, you see, I can't see the chat for some reason.
Most people are saying no, they haven't seen this.
Really also, yeah. So I guess we practice in London, so we have a lot of people coming in from the African continent. We also have, I work in Southeast London, which has a big Afro-Caribbean population, many people from Ghana, so we do tend to see this from time to time. It is not commonly diagnosed here, even in London, but just so that you know, there are infective causes. So what would trigger you to think of something like this? Foreign travel. Always ask them where they've been. Always, I wouldn't pack the ulcer, Samantha. It's diagnosed usually by biopsy. You take biopsy and you send it off for microbiology and culture, asking for the diagnosis of query TB. And just know that TB can cause ulceration on the legs, even if you didn't know it was Mycobacterium ulcerans. If you knew that TB could be a cause of this, then, or an infective cause of this, then your local infectious diseases team can do the stains, the relevant stains for you. Okay. Would I pack the ulcer? No, I wouldn't pack the ulcer. Lara has typed a question which I can't see. Can you see?
Yes, so Lauren is asking, is this sort of an urgent referral to dermatology? How sort of serious or urgent is it?
Usually these things get picked up after the infection has been going on for some time. I would classify this as an urgent referral. If you've got a non-healing ulcer, you've got a history of foreign travel, I would refer to dermatology so that they can do a skin biopsy, and they can take the relevant history. So yes, I would say that refer this one urgently, because this man's walking is probably severely impaired as a result of this ulcer being on both legs. So functionality. Yeah. Any other questions on BURULI ulcer before I move on? Yeah. Okay. So I'm going to go back the slide and the top right hand now. The top right hand, can someone describe to me what they see in the top right hand image on this person's foot? You said fungation previously. What would you, I agree with the fungation. What do you see on the base? What color is it? Anybody?
Brownish, some necrotic tissue, someone's saying they're seeing.
Yeah, so I would if it's difficult on dark skin, isn't it? Because on dark skin, on white skin, this would probably be more apparent, but on brown skin, you've already got pigment. And on top of that, I see purple red. So it looks like a purpley red base with a exophytic or fungating center. And can anyone can anyone see on the top extreme right hand image, there's another purple nodule, which is on the dorsum of the toe. Everyone appreciate that? So the purple nodule has got significance here, and the purple base has got significance. Is anyone going to take a stab at the diagnosis? Or the
got Alison saying melanoma, a couple of people saying melanoma.
Okay, yeah, melanoma is a good thought. Anything else? But because we're talking about infective causes, what would you think? It's a difficult one.
Necrotizing fasciitis or a parasitic infection?
Necrotizing fasciitis would be more widespread, a bit more like the PYODERMA picture to look at. So I don't think anything can start off and become necrotizing fasciitis or an ulcer, which is spreading rapidly. You would often do an INR level. An INR level is often high. They can go into metabolic acidosis quite quickly. So that it's the clinical picture that decides the necrotizing fasciitis and also swabs. But this isn't necrotizing fasciitis. And usually necrotizing fasciitis isn't purple. Melanoma, very good thought. What is on black skin, which is purple, and it can be associated with an illness that we had an epidemic of in the 80s?
HIV related, a lot of people are saying.
Exactly. HIV related purple nodules. Anyone know? Kaposi's sarcoma. So this is Kaposi's sarcoma and ulcerated Kaposi's sarcoma. And Kaposi's sarcoma can present as a solitary ulcer on someone's foot. Always look out for the purple edges, but also more so purple nodules on people's skin. So if you've got an ulcer which is non-healing and it's surrounded by purple nodules, patient has HIV, then yes, sure shot, they need to have a biopsy to confirm Kaposi's sarcoma. And can you have Kaposi's sarcoma without HIV? Anybody?
A few people saying, well, lots of people saying yes, they think so, yes.
Exactly. You can get HIV. A lot of Kaposi's that we diagnose is without HIV because you can have endemic Kaposi's sarcoma. Endemic Kaposi's sarcoma you can see in this slide. It can also be associated with other conditions from the Mediterranean. It can be associated with diabetes. It can be iatrogenic. And it's a condition where you get vascular hyperplasia of the associated with blood vessels within the endothelial hyperplasia, and you can treat this quite easily by treating either HIV if it's associated with it, but you can also treat it sometimes with excision if they're solitary nodules, or you can give them radiotherapy, cryotherapy, destructive treatments. Pulse dye therapy, laser can be used, but I have not seen that being used mainstream. You can use electrochemotherapy with bleomycin to destruct the lesions. We often send these cases to our specialist oncologists who treat them with radiotherapy. They tend to melt away with radiotherapy most commonly. Any questions on Kaposi's sarcoma?
Aylin's asking whether it's fairly rare. Do you come across this very often?
We do actually, yeah. So we do come across this quite often. We do have a big HIV population where I work, but we also have an endemic population of people with Kaposi's, so without the HIV. And obviously, you know, Kaposi's can be is an AIDS defining illness, and it can be the first presenting sign. So they don't always need to have a diagnosis made of HIV, but think of it and always do a test if they've got Kaposi's. But do I see it with HIV more often? Yes. Do I see it without HIV? Also, yes. If I were to describe a percentage in the last maybe 2-3 years, I'd say maybe 60% I've seen with HIV, 40% I've seen without HIV. Okay, so right, so that's Kaposi's sarcoma. Now going back the slides again to the bottom image now. Can people describe what they see on this baby's foot?
Epidermal loss, blistering, peeling skin.
Yeah. Would you describe this as, so if you look towards the little toe, would you describe this as an ulcer? Or would you describe this as an erosion? Do you know the difference in dermatology terms? Can anyone tell me the difference between an erosion and an ulcer?
Most people are saying no to ulceration, it's erosion.
Okay, so on babies, this is superficial. You can see erosions and ulcerations. So it was a little bit of a trick question. Depends on where you look on this baby's foot. But erosion is when you have partial loss of epidermis, and you have got ulcer when there's full thickness loss of epidermis, and you're seeing the dermis underneath. This is a baby, so the skin on the baby's foot is quite thin. So there's a presence of both. I can see why you're calling this blistering. It looks as though blisters have popped and peeled, or flaccid blisters have taken place on this baby's foot, and there's definitely peeling associated here. But you can see there's no real inflammation going on. I hope you can appreciate that from this baby's image. Now, does anyone know of a congenital infective condition which can be transmitted from mother to baby, which can cause ulceration on the feet and hands in particular? Anyone can give me a few differentials that they would think of?
You've got a strep G and strep B infections.
Streptococcus can cause ulceration for sure, not necessarily, congenitally in the congenital age group, not necessarily hands and feet, but it can cause ulceration. Yeah. Anyone think of something that's transmitted from mother to baby?
A couple of people saying hand, foot, and mouth. Herpes is another one.
Okay, so it is an infective condition. This is congenital syphilis. Congenital syphilis can be passed on, and syphilis, you all are probably dispersed all over the country, but during the pandemic, there has been a rise in cases of syphilis, and we have seen more cases of congenital syphilis. It's a rare, well, is it rare? It's rare in children for sure, because usually it's picked up when before the mother delivers, so treatment can be given. But when babies are born with ulceration or erosions of the hands and feet, you must think of syphilis, and you must check. You do sexual health screen with the mother, and also check the baby for congenital syphilis. Rare but possible and seen. This is the management. It can be easily treated with penicillin, usually injectable iron penicillin, and it is often painless. So the baby is not really necessarily in discomfort with this condition, which you would think they would be. With herpes, you can get blistering for sure. You can get erosions. Usually they are painful blisters. Okay, coming on to this condition. Now, anyone could describe this rash for me on this person's leg and arms?
You've got vasculitis.
Okay, if you could describe it for me. So what do you see?
Punched out.
Yeah.
Dark centre with raised purple edges.
Yeah, I think the raised purple edges in the beginning has got everyone thinking about raised purple edges. Yeah, I see what you mean. I would say that these are definitely punched out. They are multiple full thickness ulcers with a central brown eschar. So it's making the eschar, the image quality isn't great. So I appreciate the edges look overhanging and purple, but they're not. It's on a background of non-inflamed skin, but you have got a black necrotic eschar with punched out ulceration. When you see this in multiple areas on hands and on feet, what do you consider as a diagnosis? But bear in mind, we're talking about infective conditions.
Topical, we've got someone saying monkeypox here.
Monkeypox is a possibility, you know. I'm looking at it in the light of monkeypox, you know, that we've seen recently. And yes, it could be a possibility. That's definitely one on the differential. And a very reasonable differential.
Parasitic is someone else's suggestion, or anthrax.
Exactly. This is cutaneous anthrax. So cutaneous anthrax it is actually common in farmers. It's seen in England. You can see here now my Q&A is blocking my screen.
Well done, Claire Martin, for coming up with that.
Exactly, that is not an easy diagnosis to make. Cutaneous anthrax can be seen, it starts as a blister. You often see it with contact with farm animals, and it appears within 7 days after contact. Cutaneous anthrax is treated or can be treated with oral doxycycline, and can be treated with IV strip iron penicillin. It can be also treated with a monoclonal antibody inhibitor called raxibacumab, and that's when other things fail. Anthrax is common within the farming community here, or when children or adults have visited a farm to ask about where they have been. It is a diagnosis to be made on microbiology. And very, very easily treatable. So well done on recognizing that. So the key, multiple punched out ulcers with a central black eschar. That's what you're looking for. Okay.
Somebody's asking, Sweta, if it's untreated, can it be fatal?
Well, cutaneous anthrax, no, but if anything becomes systemic and it goes into your bloodstream and it's not picked up and it's not treated, then yes, of course. But cutaneous anthrax usually is picked up and usually is very easily treatable with antibiotics. Yep. So I'm hoping that, you know, most people by us doing this talk and spreading it far and wide, people will be picking up anthrax. That situation won't arise, but any infective condition, if it's allowed to get into the bloodstream and if it's allowed to stay long enough, then yes, of course, it can be fatal. It would be a shame if that was fatal, though. Okay, so now coming on to other quite dramatic ulceration. Now, what do people see in these images? The top left-hand image. I've got my left hands correct now.
We've got surrounding erythema and swelling.
Yep. So
angry red granulation tissue.
Yeah. We're just talking about the top left hand for the moment. Yeah. But I appreciate there's angry red on the bottom. On the top, what do you see? Again, ulceration, well demarcated. It's got a red, this is type 2 skin, or this is white skin. So you can see a purple red periphery. Would anyone say that this is overhanging? Just yes or no.
Got nose.
Very good. Yeah.
Lot of nose.
Very good. So because I put this picture in particularly to show you the difference between the other overhanging edge and this this isn't an overhanging edge, although this is purple. They're well demarcated. They're present usually on the medial aspect of this person's foot, and you can see on the bottom, it's when you leave it to progress, you can get a picture which has got kind of yellow granulation tissue, which is obviously, all of you know that this is not healthy granulation tissue. Anyone going to have a stab at the diagnosis here? It's very, very, very painful for this patient.
Necrobiosis, chemical burn, calciphylaxis.
Yeah. Okay, so this is calciphylaxis. Calciphylaxis can be often associated on both legs, often present on, can be present on the medial or the lateral aspect really, but it's bilateral usually. It's intensely, intensely, intensely painful. It's associated often with underlying renal or kidney failure. Often there are people on dialysis waiting a transplant. You can treat the calcium with sodium thiosulfate. You can give them hyperbaric oxygen. You can treat the underlying, usually, you know, the underlying treatment of the renal problem gets rid of the excess of the calciphylaxis, but sodium thiosulfate seems to work very well medically. I have seen some of these lesions having to be treated sometimes with, we try to promote granulation in these with some compression, as we touched upon earlier, but compressing these legs can be so painful for the patients without any treatment with sodium thiosulfate. So sodium thiosulfate, assess for hyperparathyroidism, try to correct the electrolyte abnormality that they have, try to correct the underlying renal problems. It's a difficult treatment. It's a difficult condition to treat. Hyperbaric oxygen has been used, and compression can definitely be used if it's not too painful for the patient. Okay, any questions on calciphylaxis? For those of you who work in a renal transplant center, we see a lot of calciphylaxis, so it is quite common. Okay, now to give you the difference between that condition and then another calcifying condition. This is a condition called calcinosis cutis, and I hope you'll be able to appreciate the punched out ulcers that you can see in this image. And you can see that there is background redness, but you can see the white stuff coming out. And this is what this lesion to touch was, you know, a hard, indurated, not that painful, to be honest. So between calciphylaxis to calcinosis cutis, doesn't have to be too painful, but there's deposits of calcium here. This person had had trauma to this area. Trauma, tissue damage from infectious causes or just from trauma can cause calcinosis cutis. And often they have normal serum calcium. It can be associated with all of these conditions. You can associate varicose veins, tumors, dermatomyositis, other connective tissue diseases, and the treatment ranges from topical to systemic steroids. You can use other conditions such as probenecid and colchicine. Treatment of, if they have got underlying associated conditions, then treat those conditions. But in this particular gentleman, we had to excise these areas, take away all the calcium and allow it to granulate, because obviously the calcium is preventing the vascular supply getting to the skin, and it's preventing the ulcer from healing. So you literally, we had to debride this, all the calcium, and cut it out effectively. So it was quite a severe case that we saw at King's, and I'm going to thank some of my colleagues who shared these photographs of their case with us for your education today. Can
we just ask, sorry, Sweta, someone's asking about diagnosis for that. Is it really just what you're seeing, so it's presentation, or is there anything else you do to diagnose that?
So we would often see that, diagnose it, have a clinical suspicion of calcinosis cutis if you see the white, because you can see literally the white calcium coming out of the skin, but it would be a tissue diagnosis. So you would do a biopsy and we'd see the features of calcinosis cutis, which would be different to calciphylaxis on histology.
Okay, thank you.
Yeah, okay. So for both of these conditions, you would need to have a tissue diagnosis in the form of a skin biopsy. So I'd get your dermatologists involved quite quickly if you saw this. So if you see a non-healing ulcer with white firm material coming out of it, always think of calcium deposits. If you see a painful ulcer with a red purple edge, no real firmness to it, but really painful, think about calciphylaxis, especially if they've got underlying kidney problems. Coming on to quite a significant ulcer that you can see on the left hand image. Does anyone want to describe what they see and where they see it on this image here?
People are saying it's a raised fungating ulcer, so they're seeing overgranulated tissue.
Yep. Would you expect this ulcer to be painful? Just yes or no?
Yes, most people are saying yes.
Yeah, and when you see an overgranulating or a fungating mass like this in an ulcerated form, which is painful, what is your top diagnosis?
People are saying malignancy.
Yeah, so can anyone tell me which type of malignancy? You're very good at diagnosing these, actually, because we get a lot of referrals from you questioning this.
Squamous cell.
Mm-hmm. Yeah, squamous cell, this is a squamous cell carcinoma. Melanoma can also look like this, a malignancy of any description, really, a fungating mass, which is painful, rapidly growing, indurated base. You have to do a tissue diagnosis. You have to have a tissue diagnosis, rather. You have to do a biopsy to confirm that this is or isn't a squamous cell carcinoma. So anything which is overgranulating, painful, growing quickly needs a biopsy until to exclude malignancy. So you would not want to be compressing this and continuing to compress this. On the top image, what do people see? The top right hand image. What do people see on the top right hand image? How would you describe that? It's the site of that and the
So we've got here mixed wound bed, overgranulation, some of it, hypergranulation, slough, eschar.
Where is it?
Most people are saying, well, lots of people are saying lower leg, gaiter.
Yeah, so say this was on the medial part of someone's leg, what would be, so medial calf, just above the ankle, what would be your two differential diagnoses?
So we've got martoral, no overt venous disease, martoral, venous disease.
Yeah, so this is a Martorell's ulcer. A Martorell's ulcer is an ulcer which arises due to long-standing, untreated, uncontrolled hypertension. This is an ulcer where you treat the hypertension and you do compression bandaging for after you've done an ankle brachial pressure index and excluded underlying arterial disease, and you do localized wound care. The top right-hand image, the top left-hand image was actually a MARJOLINS ulcer, which resulted in a squamous cell carcinoma. Does anyone know what a MARJOLINS ulcer is? What's the difference between a Martorell and a MARJOLIN?
People aren't sure.
Yeah, so Martorell is always associated with hypertension. A MARJOLINS ulcer is just an open ulcer which has been there for a long time, and a long-standing ulcer which has resulted in squamous cell carcinoma formation. So that's a MARJOLINS ulcer. Often people associated with burns, burn-like trauma. Long-standing exposure due to burns. Okay, that's the difference between Martorell's and MARJOLINS. And sickle cell ulcers, people were asking, somebody said sickle cell ulcers previously. So this is, you can see here a type 6 skin, and you can see these punched out ulcered areas. Can anyone tell me, like, what is the striking feature in this photograph? What do you not see?
Sweta, I've just given you a time here. I've got 4 minutes before the webinar is due to finish.
No problem. What do we people see as the do not see in this image? Any quick answers? No.
There's no oedema, no granulation. It's dry.
Yeah, and there's no inflammation, is there? There's no surrounding redness. There's no kind of suggestion that this is painful, but this can be incredibly painful. And this is almost due to, like, you know, infarcts of the skin because of the sickle cell disease. I'm going to very quickly go through some other forms of ulceration. This is leukemia cutis, which is deposits of hematological malignancy called leukemia, which can also lead to ulceration. This is champagne bottling of a person's leg due to venous disease. You can see the narrow ankle and the thickened calf and the purple induration. This is called lipodermatosclerosis associated with venous ulceration, long-standing venous disease. This is an image showing you the progression of venous disease, and also most commonly in venous disease, I see more and more commonly one perforating vessel leading to venous eczema. So if you have a solitary area of eczema on someone's foot, think about underlying varicose veins or underlying venous disease, which may not be totally clinically apparent. I've seen a lot of these and they get treated with compression stockings, but it's due to microvascular disease. Management of venous ulcers, you all know, and you're really good at. The new thing is platelet-rich plasma therapy, which is autologous. You take someone's blood, get the platelet-rich plasma, and you can sprinkle it on wounds. And that has been known to improve long-standing ulcers. And that is it. So hopefully just in time, we have gone through the questions as we have gone along. I'd like to thank my diabetic foot team for giving at King's College Hospital, particularly Dr. Prash Vass for his contribution to my talk, and particularly on microvascular disease, and Dr. Daniel Prima and Dr. Duncan, who provided me photographs of the calcinosis cutis. I'd like to thank my whole dermatology team at King's who've supported me through this presentation, and our nurses in particular, our tissue viability nurses, Sister Patricia, who helps with our tissue viability and leg ulcer control. These are my contact details. Should you have any questions, I'd be very happy to answer them for you, either on social media or on my email. And if you need to send anyone to us, or you're worried particularly about cancer diagnoses, then I'm a skin cancer surgeon. I do a lot of cancer. Please do get in touch and let me know. Thank you very much for your attention this evening.
Thank you so much, Sweta. Again, that was fascinating, and honestly, we could have you here all day, and I just think the interaction was brilliant, and I'm sure there's still lots of unanswered questions, but please do take up the offer of advice from Sweta if need be. Thank you again, and thank you all for attending and taking time out this evening.